Okay, once again, just to reiterate, intensity is a fixed amount. In other words, if we're talking about a sound, and we can define that by how many decibels it is. So it's 30 decibels, it's 50 decibels, it's 70 decibels. Color is a little bit harder to quantify, at least for me. Other people might be able to do that. Size is an intensity, but those are fixed amounts. What is salience? Well, salience is a relative issue. Salience is a relative issue. We actually had that word a few weeks ago. Darley mentioned it in citing Goodglass and talked about linguistic salience and said that, a word that may appear at the beginning of a sentence may be more salient than a word that is kind of embedded in a phrase later on. It's a relative issue. And so let's take a sound that has a fixed intensity. And let's say it's 60 dB, and that's the loudness, and that's the intensity, and that's a comfortable intensity for an individual. But what if all of a sudden that 60 dB sound, which is really reasonably and adequately intense in a quiet situation, is now in a noise situation? And so now all of a sudden that sound is embedded in other sounds, and it's no longer whereas its intensity doesn't change, its relative ability to be perceived changes because it's now in noise. Okay, it's no longer salient. It doesn't have salience. If I have an apple and it's sitting on a table, and I want the patient to be able to perceive the apple. Show me the apple. Well, if it's sitting there on the table, perhaps next to other, a pencil and a cup and a scissor and some other item, I don't even know what, well, that's okay. It's there. And it has whatever salience it has. But what if now all of a sudden that apple, same apple, is now in a fruit bowl. And it's sitting there together with a plum and a peach and a pear and a green apple. The other one was red. I didn't say that, but let's say. Well, that same apple has lost salience. And that means for me to be able to point to that apple requires more processing resources, okay? And so if I want to enhance the ability of the patient to be able to point to the apple or perhaps name the apple, whatever the modality is, then I need it to be adequately intense and I need it to be adequately salient. I need it to be able to stand out so that I'm not wasting resources on inadequate intensity or confusing salience or lack of salience. I want it to be there, so I don't have to do that. Do we need all those things going for us? No, because we've got almost an infinite amount of resources for a task like that. Oh my gosh, how much do we need to be able to just name an apple or point to an apple? That's, a 3-year-old does that, a 2-year-old does that. But our patients are challenged because they have fewer resources. And so what we want to do is to enhance their ability by having more than adequate intensity and salience for all items. Is that the way we're happy? No. If a patient needs that, that's a statement of severity, isn't it? But along the way, they're going to be able to deal with situations that are less favorable so that it's not quite as intense, it's not as salient, and they'll still do well. That's sometimes a mark of a patient getting better. Okay. Clarity. We need stimuli to be clear. We need them not to be muddled. We need them not to be indistinct. It's hard to separate that from intelligibility. Although we tend to think of intelligibility in an auditory sphere, but we can think about it in a written sphere, in a visual sphere as well. Is it written clearly? Is it intelligible in a visual sphere? The more clear, the more intelligible, and again, to a point, it just has to be unambiguous. It has to be obvious that it's clear and it's intelligible. Then the patient doesn't need to have to expend other resources in order to find that stimulus, okay, and to be able to interpret it and then have to name it and then have to point to it. Okay. How much of that do we need to do? How much can we get away with in any of these? Well, that depends on each patient. And that's something we need to explore. And that's usually something that we see in severity. So basically what we're saying is the patients that we tend to label as being more severely impaired need greater intensity, greater salience, ultimate clarity, ultimate intelligibility. Okay. And they will do better then because they have fewer resources. Okay, and we don't want to waste the resources in finding the apple, and then when it gets to actually naming it or pointing it, they don't have any resources left and they can't do it. Okay. Redundancy. Redundancy is also a term that Darley taught us before. Redundancy doesn't just mean repeating something. Redundancy is in a multiple cues within a stimulus that might help us. So if you recall, the example that Darley gave us was the cat that is furry. Okay. And what's redundant about it is that furry is more information than we need typically to be able to define or to describe or to identify a cat, right? And in fact, that's extra cues that some patients will benefit from. Okay, but it's hard to know because if you recall that the data that Darley shared with us from that one study, he said that the patients did best actually when they just heard the word cat, just the word cat, not point to the, and not the cat that is furry, and certainly not the cat that is sour, which was a counter redundancy. But if the word cat with adequate intensity and adequate salience and adequate clarity and adequate intelligibility is stated, then most patients will do best with that. But what if they don't? Well, then maybe they need the redundancy. Maybe they need the next word, the context. Maybe they need the pet that is a cat that is furry. Maybe they need all that information to grasp, oh, that's what a cat is, right? The furry thing, the thing with a tail, the thing with ears, the thing with stripes, the thing with 4 legs, not the thing with 2 legs. And so redundancy might help, it might hurt, but it's a feature of a stimulus that we need to manipulate. We need to manipulate it correctly for our patient at that time, okay? And again, it may be the wrong way to manipulate it next month, and it may not work at all for a different patient, okay? All of this is individualized for that patient for that day. Stimuli need to be novel. They need to be interesting. It's boring. Again, Darley talked about that one patient who said that your therapy tends to be so boring. And it tends to be, right? We tend to use the same kind of materials. We use pictures of common objects, and we use common objects themselves, and we ask a bunch of questions. But they're boring. You know, what'd you have for breakfast today? Who cares? Do we ever talk about that with our friends? Do we ever get together and say, so what'd you have for breakfast? It's not normal. It's not novel, and it's not interesting. We do that because we don't really know what else to talk about. Well, find something else to talk about. And don't do the same thing every day. Come up with stuff that is novel, come up with stuff that is interesting. And again, that has to be individualized. That has to be appropriate for that particular patient. We need to give cues, and we need to give prompts. We're going to talk about that a whole lot more next week when we talk about cueing hierarchies. We need to be able to help the patient get into the set to give them extra information. Maybe it's a question of what does that item do? So we might say, point to the apple that is a fruit, point to the apple that is red, point to the apple that is round. It might be a phonemic cue, like the a. What is it? It's an a, so we're giving a sound cue. Maybe we're going to give a verbal cue, like, okay, what is it? It's a fruit, and we're pointing to the apple, that kind of a cue, that kind of a prompt. Now again, this works in both directions. Some patients will be overwhelmed with cues and prompts because it's too much information. And then they're wasting their resources in dealing with the cues and prompts. And when it gets down to the response, they have nothing left. Other patients are enhanced by having cues and prompts. Which cues, which prompts, I can't tell you. We have to find out, and we have to find out for each and every patient. What about in the responses? Can we manipulate, can we do something about the responses themselves that will enhance and make it easier for a patient to respond when they don't have, and they, by definition, do not have normal amounts of processing resources? Okay, well, if we ask for a longer response, then that's going to require more resources, won't it? Now, sometimes we need to have that longer response because that's what we're up to. But what if it's arbitrary and we really don't care? So what if we just say, all right, I want you to tell me the name of these things, but use a complete sentence? Well, why do I have to use a complete sentence? You want to know the name. Okay? For whatever reason, you're working on naming ability. So why make it a complete sentence? Why do I have to be able to say, it is an apple? Why can't I just say apple? And if I can do that, and if I can focus on that, then it's more likely I'm going to get the word apple correct, instead of wasting resources on sentence structure. Or if I make it less complex, or more complex in my responses. And again, if in fact that's your goal is to work on complexity, then that's what it is. But hopefully the patient's able to do that, and he's ready for that. But if they're not, and for some reason, almost an arbitrary reason, you've embedded or you've added complexity to the response, when in fact you'd be happy with a simple response that's accurate, well then get rid of the complexity and let the patient focus and dwell on accuracy at a far more simple level. We know for a fact that patients will do better with items that are more familiar. Schul told us that often items that are more meaningful, items that are higher frequency of occurrence, items that are more common, items that are within the environment of the patient, things that mean something to them. Even if it's a simple repetition task, it's much more likely that I can repeat a word that I know and that I know easily than I can repeat a word that I'm really not that familiar with, or maybe a similar sound structure, but it's not even a word. It's a nonsense word, or it's a different language. Well, why? I should be able to repeat words in Greek, shouldn't I? And in fact, I can. But that takes a lot more resources for me to be able to do that than to repeat a word that is easily available for me in my native language. Okay, and so those issues are important issues. What about imposing a delay? What if I make the patient wait before he responds? Because I want him to think about it and then do it. Well, for some patients that might help. It might help and they can kind of plan and they can think. But for some patients, the longer they delay, wow, they just lost it. So you said, tell me the name of that. And in their head, they had that word, but you said, don't respond yet. Well, and now you say, okay, now. Well, by now it's gone. So they're not holding it. And so the delay, again, these can work both ways. Some patients will benefit, some patients will not. Response redundancy. What if we have things that are, if I say, don't just say the name of this, but tell me the name of it and its color and what you do with it. So apple is no longer acceptable. It has to be a red apple that we eat, or it's a red apple that's a fruit. Well, again, that redundancy may benefit, that redundancy may really make it much more difficult for us. Okay. What does resource allocation tell us? Resource allocation tells us that we have to seriously think about how we structure our tasks, how we set appropriate goals for our patients, how we create stimuli that are more likely to elicit correct responses than are likely perhaps not to. It's individualized. It is, to my way of thinking, it is perhaps one of the most important things we need to be able to think about when we plan therapy. It often, to me, makes the difference between good therapy and bad therapy, or canned therapy, which is never good therapy, because that makes an assumption that everybody's the same, and everybody's definition different. We're different before we have strokes. We're different after we have strokes, for sure. Okay. Okay. We'll leave it at that. Thank you.